ADHD, course and its management. Introduction. The syndrome of restless, inattentive, and impulsive child behavior is known as attention deficit hyperactivity disorder, called in short form ADHD. Biological factors such as genetic risk are clearly implicated in the neuropathology of ADHD. A psychological process, particularly deficit in inattention and informative processing, uh, mediate the link between the underlying neuropathy and the behavioral manifestation of the disorder. Social influences are significant determinants of the impairment associated with the disorder, the prognosis for individual children and its therapy. The cardinal features of ADHD are excessive and impairing level of activity, inattention, and impulsiveness. There are some uh, features in DSM-4 and ICD-10. In ICD-10, they tell that he fails to give close attention to details, makes careless mistake, fails to sustain attention in tasks or play activities, does not seem to listen, fails to follow instruction, has an impaired ability to recognize tasks and activities, avoid or dislike tasks requiring mental efforts, loses things, is easily distracted by external stimuli, is forgetful in daily activities. Uh, Forgets, leaves seats, run or climbs excessively, is undue noisy when playing, has excessive motor activity. These are some points regarding impulsivity. Uh, Blurts out answer, has difficulty waiting for his or her turn, frequently interrupt or intrudes, talks excessively. Their comorbidity 35% is ODD, 25% CD, and 15% depressive disorder, 25% anxiety disorder. Over 50% meet the criteria for two comorbid condition. Intellectual disability 12 to 25%, language impairment 5%. Course and prognosis. Originally, ADHD was thought to be largely a transient phenomena. In general, there is a tendency for symptoms, especially restlessness, to diminish when children reach adolescence, although inattentiveness and impulsiveness are more persistent. It is now clear that the disorder persists into adolescence in half or more of the affected person and into adulthood in half or more of the adolescent cases. Compared with their non-ADHD peers, approximately 5 times greater risk for substance use like tobacco, alcohol, illicit drugs. Antisocial behavior are more common in ADHD, like arrest, incarceration, aggression, trouble with the law, admission to juvenile facilities. Other psychiatric disorders such as depression and anxiety. Academic and educational problems persist into adolescence. By the time they are adult, hyperactive children have completed significant less schooling and hold lower status job than their non-hyperactive peers. Even those who no longer meet the criteria for ADHD in adolescence are at increased risk for substance abuse and antisocial behavior, suggesting the persistence of some residual or latent deficit. Poor outcomes. Child living in adverse psychological circumstances like poverty, crowding, hostility in the parent-child relationship, parents with ADHD or other psychiatric disorder, the outcome is also worse when ADHD symptoms are severe and persistent. Comorbid conduct or language or learning disorder in his or her early development. Problematic social interaction are a major determinant of poor outcome in adolescent. It is estimated that up to 60% of the children with ADHD will continue to have significant ADHD and related symptoms persisting into adulthood. It has been estimated that 5% of the global population has ADHD, including cases not yet diagnosed. In some cases, the hyperactivity may disappear, but the decreased attention span and impulse control problem persist. Overactivity is usually the first symptom to remit, and the distractibility is the last. ADHD does not usually remit during middle childhood. Remission is unlikely before the age of 12 years. When remission does occur, it is usually between the age of 12 and 20. Remission can be accompanied by the productive adolescence and adult life, satisfying satisfying interpersonal relationship and few significant sequelae. Most patients with the disorder, however, undergo partial remission, vulnerable to antisocial behavior, substance use disorder, and mood disorder. Learning problems often continue throughout life. Adult ADHD. About one-third to two-thirds of children with symptoms from early childhood continue to demonstrate notable ADHD symptoms throughout life. WHO World Mental Health Survey Initiative screened around more than 11,000 uh, people. On this basis, they estimate that the adult ADHD proportion of the population to average 3.5%, with an lower prevalence in low-income countries. High-income countries are having more prevalence. Men with childhood ADHD have higher rates of ongoing ADHD, antisocial personality disorder, substance use disorder, and psychiatric hospitalization in 24% cases. Men with childhood ADHD also had lower educational level, lower occupational achievement, lower socioeconomic status, lower social functioning, higher divorce rate, imprisonment, and high mortality. Treatment is the first one is pharmacological, second one is behavioral, and combined pharmacological and behavioral intervention both. General principle is a comprehensive assessment is the logical starting. This assessment must be identified as core HKD symptoms, impairment in language and learning, concurrent emotional and behavioral condition. The treatment plan must consider child's social context, quality of current schooling, nature of parenting practice, and parenting understanding. The treatment must be flexible for each child and family. Based on the available evidence, medication plays an important role. Rarely is medication prescribed as the sole treatment. For some children and families, medication will be an undesirable therapeutic option. For others, medication may be unnecessary or premature. Families who are not ready for or capable of